Alright, so this is part 4. This is our reproductive series continuing. We touched briefly on uterine malformations in the urinary module. This is going to discuss both female and male reproductive issues, starting with the female. Ladies first. So 2 critical findings on this examination here. This one and that one. Don't want to miss the median sternotomy in this case. Yes, the sternotomy wire is intact. Alright, 3 main types of questions, similar to the prior talk, starting out here with one of these. So, if you see an HSG, there's a couple of things you need to think about. One is going to be malformations of the uterus. I think that's, if on the oral board's examination, it would have been completely fair game, and believe me, it still is fair game. Anything is fair game. But I think that uterine malformations are more likely to be shown in MR, as it is the quote test of the future. But they can certainly show them in a 3D ultrasound or in the traditional modality here. I think that this is more likely to show either this entity or Asherman's syndrome, which would be a bunch of like filling defects within the uterine cavity itself. Another possible question that you could get related to this is contraindications for doing this procedure, which is basically the big stuff. Contrast allergy, any kind of active infection. You don't want to be flushing bugs, around in there. So if they've got PID, active PID, you don't want to do it. If they're pregnant, you don't want to do it, obviously. That seems like a no-brainer. Those are the big ones. Alright, so let's take a closer look at this case. So this is one of the other entities, besides Asherman's, that you should know, and it's SIN, SALPINGITIS ISTHMICA nodosum, which is basically a bunch of nodular scarring that happens in the tube secondary to infection or inflammation. And it produces this really classic appearance of a bunch of balls and sort of, I guess it's sort of tree and bud looking, but nothing else looks like that. And yes, it's bilateral in many cases. This side it was unilateral. And it's associated with infertility, which shouldn't surprise you. You would think that tube wouldn't work right. Okay, so this versus that compares 2 different pathologies that are completely different, but that have very similar sounding names, and therefore would make great multiple choice distractors for each other. So, have a closer look here, and we can see a nice thick junctional zone. So the gallbladder ultrasound, well, let's start with the MR here. So this is adenomyosis. This is, as you would expect to be in the reproductive chapter or module. And then the companion here is adenomyomatosis, a completely different entity that's basically cholesterol crystals, hyperplasia of the wall with cholesterol crystals trapped in these Rokanowski-Ashkoff sinuses, which are basically intramural diverticula. It has a very typical appearance. It has a very classic ultrasound artifact, and which is a type of reverberation artifact, and we'll talk about that in the ultrasound physics modules. But the names are super similar sounding. You probably have heard somebody in a case conference at some point mix these two up. Believe me, if I was writing a multiple choice test for either one of these entities, I would have the other one as a distractor. So what is this guy? Basically, you've got endometrial tissue that has grown into the myometrium, and the classic history is a reproductive age woman who's had multiple kids, tends to favor the posterior wall and spare the cervix, and the diagnostic criteria is greater than 12 millimeters in the junctional zone. Now, you can show this with ultrasound. It's tougher. It would basically just be sort of a bulky, thick-walled uterus. Sometimes they'll have some hypercoic stuff there, but it's way easier to show this in MR, and if I was going to show a case, but that's how I would show it. So next case here, ultrasound, and what we've got is a pretty thick endometrium. We've got calipers on stuff. Remember, I've sort of touched on this a few times before. How do you know it's too thick? Because it has calipers on it. As a general rule for multimodalities with regard to multiple choice, when you see calipers on something, I would just assume that it's either too big or too small. In this case, we've got something that's too thick, but it's not just too thick. It's got a bunch of sort of cystic-looking spaces in it, and that's a pretty typical look for tamoxifen. And if you remember from medical school, tamoxifen is one of these selective estrogen receptor things that acts like estrogen in one part of the body and acts like a blocker in the other part of the body. So it's typically used for breast cancer, and it blocks the effects of estrogen, which is a primary cause of all breast cancers, on the breast tissue. Of course, there's lots of breast tissues that have estrogen and progesterone receptors on them. So it's a hormonal therapy for breast cancer, but it actually acts like an estrogen agent in the pelvis, and as a result can actually increase the risk of endometrial cancer. It causes these cystic spaces. It also causes endometrial polyp formation, and it will normally thicken the uterus. So whereas a normal postmenopausal endometrium shouldn't be more than 4 or 5 millimeters, this would get a pass all the way to 8. So you'd expect it to be a little bit thicker. So what if you thought there was a polyp in there and you couldn't see one? Is there any other test you can do? Well, apparently there's a thing called a sonohistogram where somebody, hopefully not me, puts saline, you cannulate the cervix and put saline into the uterus, and then ultrasound again to sort of spread things out, and it can look a little bit like that. You've got your hypercoic polyp here. All right, so let's just do a really quick didactic on endometrial cancer. Just like in the breast, unopposed estrogen sort of causes changes that eventually lead to cancer. And there are two main peaks. One is in a perimenopausal person, and then the other one is in an old lady. And I separate these out because they behave a little bit differently. The perimenopausals are more estrogen-dependent cancers. They do a little bit better. And the older person, it's more of a spontaneous situation that arises out of an atrophic endometrium, and they don't do nearly as well. So that if you were asked which of the following has a worse prognosis, basically being old and having endometrial cancer is better than, or is much worse than being young and having endometrial cancer. And the way that I remember that is that it's just stranger because it doesn't follow the estrogen model. So strange is bad with regard to cancer. So how do GYN docs work up abnormal bleeding? So you're supposed to have some bleeding, once, assuming you're not on any kind of hormonal therapy. Women bleed normally, but when they've got persistent bleeding, or bleeding past the expected age of menopause, this is considered abnormal, and then it gets a workup because there's a couple of different causes. The most common is atrophy. So there's a normal, it becomes too thin and then it bleeds. But the thing that you worry about is not atrophy. The thing you worry about is cancer. So that's the whole purpose of the ultrasound. So you get the ultrasound, and then the ultrasound is basically going to tell you if it's too thin or too thick. Too thin is assumed to be atrophy and will probably end up on some kind of hormonal therapy. Too thick gets an endometrial biopsy to see if it was hyperplasia, cancer, or a polyp. So what's the critical stage? So throughout my series of talks, I'm gonna anytime I encounter a cancer, I'm gonna try to make a point, because people get obsessed with trying to memorize these staging, and there's just so many of them. It's nearly impossible to memorize all of the stages for all the different cancers. It's really, really tough. So my idea for looking at these cancer stages, as far as what you need to know, is to look at what's the most likely question. And I think the most likely question is any time that it's going to change therapy, it's going to change the surgical approach, it's going to change whether or not they get radiation, or any kind of a change to management and it's something that the radiologist can actually tell. That would be what I would consider a critical stage, and I would think that that's the thing that you need to know. So in this case, myometrial involvement more than 50%. So why does that matter? It matters because they've had some studies that show that a pelvic lymph node is more likely to be positive in someone who has 50% or greater myometrial invasion. And because of this, they will get a lymph node dissection, and because of that, they may end up with pelvic radiation. So MRI has kind of a limited role with regard to endometrial cancer workup, and this is one of the roles, is to look to see how thick it is. So like, why would you do it? That would be the answer of why you might do it. All right, so how about this? So anytime you throw on Doppler on stuff in the endometrium, myometrium, this is something that you need to have like in your mind, especially if you see something like that. So if they throw Doppler, that's actually generating a waveform anywhere that's a solid organ, you should be thinking about some kind of fistula or AVM. So these can be acquired or congenital. They're usually acquired. They're usually after you've had some kind of a trauma to the uterus, either a miscarriage or a DNC or a C-section, some kind of cutting. And classically, you're going to have Doppler that's going to be low resistance with a high velocity. Think about almost certainly to be shown on ultrasound. It'd be really, really sneaky to show it on MR. I don't think they would do that. All right, so we've got two different MRIs on two different patients, and these are both cervical cancers. One of them looks, the yellow arrow one looks sort of worse than the red arrow one. But just like my discussion on endometrial cancer, a staging question is going to focus on what matters as far as when does management change. So the big thing to know is, when does it involve the parametrium? And this is to be or not to be, because that's going to result in a change in management. Surgery is limited to stage 1 and stage 2A, assuming there's no extension into the parametrium. You can end up with, well, you can have surgical treatment, If there's parametrial involvement, then you're getting chemotherapy or radiation. So how do you so I don't even know what the fuck parametrium is, or I didn't when I was a resident. I was like, I don't know what that. I've heard that word. I'm not really sure what that means. So this is what you want to look for if you happen to be shown. Normally, there is a dark ring here. It goes all the way around. And this is your cancer here. That ring should be intact. If it's not intact, then you have parametrial invasion. So this is a case where it's intact. So that ring is holding on. This is two examples when it's not intact. So here and here, you could see disrupted, right? Black ring here, and then it's disrupted. Here, same deal over here. This is black ring, disrupted. So that's parametrial invasion. This is so if you would happen to be asked, this is a Smith sleeve. You may have seen this at the view box. It's a therapy tool. You often they'll jam that thing in there. It's not uncommon to see it. It's not a tampon or something like that. So cervical cancer is usually squamous cell, and it's typically related to the HPV virus, certain subtypes, and this is why they have a vaccine out for some of the more dangerous HPV subtypes to help prevent cervical cancer. But I think it's important to know that it's a sin to take that vaccine. So if you're incredibly religious, you should not let your children take that vaccine because it would lead to risky behavior. Like when I got my tetanus vaccine, first thing I did was I went to the junkyard with my shoes off and walked around on a bunch of rusty nails because vaccines always lead to increased risky behavior, right? What's that thing? I thought this was a this versus that question. Like there's just one of them. All right, so this is a question that I wanted to bring up so that I could review the various cysts that occur in the GYN region. So there's 4 different ones. The Nabothian cyst is obvious. We see those all the time on ultrasound. Some people decide to measure them in multiple planes and report them in bullet form in the reports. I call those people academic radiologists. Reasonable people either don't mention them at all or just say something like multiple Nabothian cysts buried somewhere in the findings. So the next one here is the Gardner duct cyst. And this one is located anterior, right around the area of the bladder. And the way that I remember that is, after I work in the garden, I get very thirsty and want a glass of lemonade. Because lemonade is yellow, urine is yellow, it's near the bladder. There's the Skene gland, and then there's the Bartholin gland cyst. And the Bartholin gland cyst is near the butthole, and then the Skene gland is the other one. So the other one is the other one. So that's how I remember that. This is just showing it more on the conventional anatomy. Stay oriented. So let's go back to this one. This was our case. And this is posterior. below the pubic symphysis or behind the pubic symphysis, and BB for Bartholin. So I created this animation to just to make sure that you were oriented to the anatomy. This one too. You saw that, right? Yeah. Is it weird that I collect cases of patients pooping on the CT scanner? I don't think that's weird. Everybody does that, right? All right, now let's move on to some ovaries. So we've got 2 ovaries, both of which have a bunch of cyst-looking things, follicles, big ones, but they're different, right? We've got the gigantic ones that are clustered. These are the THECA lutein cysts, and we've got the peripheral, bunch of small peripheral ones, which you probably see all the time, typically in a fat girl who has fertility issues and a mustache. The mustache is unrelated to her fertility issues. Usually, girls with mustaches have fertility issues, but for a different reason. So the criteria is a whole bunch, 10 or more, peripheral simple cysts that are small. You can have enlarged ovaries, and they usually are, but about a third of patients actually have ovaries that are normal in size. I would expect that if you were shown a case that it would have an enlarged ovary. The THECA lutein cyst is seen in anyone who has too much beta HCG, and there's a couple of categories with that, which I'll talk about here in a second. But what you've got here is large cysts with this sort of multilocular cystic spoke wheel. It's a very typical classic look. So who has too much beta HCG? The octomom does. People with molar pregnancies do. Remember, they have super high beta HCGs and they get hyperemesis as a result. So those are big ones to think about. People on fertility drugs. It's another one. So this is a case of a molar pregnancy. In this case, it was a complete mole or a classic mole. And you've got your CT equivalent here. Big cysts with thin septations. And there's an entity called ovarian hyperstimulation syndrome. It's seen with fertility medications. You see these big THECA lutein cysts, ascites and pleural effusions. They can also have a pericardial effusion. And because their ovaries are enlarged, they're at risk for torsion. Bad juju. Okay, so what about this? What about a pet where you've got ovaries that are hot? There's a cyst there on the left. Is that normal? So, yes and no. In someone who has normal functioning ovaries, they are metabolically active and they can be hot. And this is why you're supposed to do your PET scan in the first week of the menstrual cycle. That would make a great multiple choice test question, because Nukes is full of trivia, right? So this kind of stuff would be perfect. When do you do the PET? First week of the menstrual cycle. Why? So you're not confused by that. You don't think that that's some kind of, something that's a cancer. And in a postmenopausal situation, they should never be hot. So if they're not working and they're not actively functioning, they should not be hot. And in that case, you should be suspicious of malignancy. All right, so what about this one? That thing. Ultrasound, I'll tell you this is an ovary. And there's a big hyperechoic plug. It's a buzzword. Okay, so gamesmanship, guys. Gamesmanship with any of these MR-type questions, gamesmanship. First thing you should do is figure out what sequence this is. We can see that we got a lot of fat, bright fat here, even though we don't see a bladder. And technically, fat can be bright on T2 also, but it really looks like a T1, right? The marrow, it just looks like a T1. So we're going to assume that that is a T1. And then over here, we've got a fat-saturated sequence. We know it's fat-saturated because we can see this stuff here that was bright is now dark. Same thing with this. This sub-Q fat is now satted out, so we've got a fat-saturated sequence. They usually do fat-sat for post-con, right? So it's probably a T1 post-con. And the point that is trying to be made here is that we are seeing we have a fat-containing lesion. Fat is saturating out within this thing. So I'll talk about this a little bit more. For the workup of ovarian masses for MR utility, fat saturation is one of the key things that you're looking for. So if you were going to design a MR sequence or a MR protocol for working up ovarian masses, you would want a couple of things. You would want a T1, you would want a T2, you would want something with fat saturation, and then it would be nice to have contrast. And that's all you need to make pretty much any of the diagnosis that you want. So a dermoid is going to have fat in it, just like a dermoid in the chest, or a teratoma, they call them, in the chest. This is very common. It's the most common mass in the ovary in a patient under 20. It's T1 bright because it has fat in it, but the fat sats out. There is a small malignant potential for these, and it's a squamous. They can be bilateral. The cancer, as I mentioned, is rare and seen more in strange cases. So an older person that's over 50, or a really big one. Because remember, most of these dermoids are in younger people. They're most common under 20. All right, moving on. More ovaries. So we've got two different ultrasound appearances of ovarian masses, one with a very homogeneous look and another with a lacy fishnet look. So the way I keep these straight is, I think about a clot that's evolving, and as it evolves, it breaks down, and that's what creates that fishnet or lacy appearance. So retracting little parts of the clot, as opposed to the endometrioma, which you should think about as a big, giant piece of chocolate that's very homogeneous. So what could you do if you weren't sure? The cheap thing, and traditionally on boards, the cheap answer was the right answer, because the U.S. healthcare system believes in not wasting things. We don't have any waste in our U.S. healthcare system because of how well we train people to go to the cheap thing first. And you can see it in practice all the time, right? There's never any waste. There's never any studies ordered that aren't indicated. That never happens. So if you were asked what you could do to differentiate those for sure, you could simply repeat the ultrasound in 6 to 12 weeks, which is 1 or 2 cycles. And the hemorrhagic cyst should continue to retract and go away, and the endometrioma should stay put. Another way to think about it is hemorrhagic cysts just look strange, and the more weird that they look, the more likely they are to be a hemorrhagic cyst. This is a hemorrhagic cyst that is like a retracting clot thing. You would not know that unless you had followed it. Now, if this was a next step type question and I said to you, the sonographers called you and shown you this picture, what do you tell them to do? You tell them to put Doppler on it. Always, masses always get Doppler. Doppler, 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 something. Some kind of color, put color on it. Show me if there's blood flow in it or not, because that is really going to be helpful. So if that thing lit up with flow, that would be a big nodule, right? And that would be a cancer. But because it's not, then you're feeling more comfortable watching it. All right, another MR. Remember I said for your MR protocol, T1, T2, and a fat-saturated sequence, and then contrast is all you need. You don't even need contrast to make any diagnosis of benign things. It's just to see if you've got enhancing components. But in this case, we've got something that's T1 bright, and then something that's T2 dark. And this is the classic shading sign of an endometrioma. And the shading sign happens because of T2 shortening, which causes it to get darker on T2. Remember, endometriomas are these, quote, chocolate cysts that are basically a blood, think about them like blood products. So it makes sense that they would be bright on T1. And yes, it's true that the dermoid is also bright on T1, but it's bright on T1 because it's got fat in it. And because it has fat in it, you would expect it to fat sat out. So the dermoid, you're looking for a fat-saturated sequence. The endometrioma, you're looking for T2 shading. Notice the dermoid is also bright on T2. You need that fat sat to tell them apart. So yes, they can turn into cancer. The dermoids can turn into squamous cell. Remember that this happens in older people and bigger masses typically. And the endometrioma can actually turn into cancer also. And the classic subtype is clear cell. Okay, so that's the conclusion of this first part of the lecture. And we'll be continuing with the male reproductive system next.